Physical examination of the respiratory system. Physical examination of the respiratory system involves general examination, systemic examination, and examination of other systems. It is important to note what we can expect from doing the physical examination in respiratory diseases. By doing physical examinations, we try to find out the structural and functional changes that might have occurred in respiratory system due to the disease and the site of these changes. These are main structural changes which can be detected by physical examinations. 1. Collapse. 2. Fibrosis. 3. Effusion or collection of fluid in pleural space. 4. Consolidation. 5. Pneumothorax or collection of air in pleural cavity. Collapse or atelectasis means shrinking of the lung tissues. There will be less air in the lungs, and hence the alveoli and the bronchi get shrunken, eventually leading to the shrinking of that particular lobe. This can happen because of 1. Compression of the lung tissue from outside, as in case of air, pneumothorax, or fluid, pleural effusion, in pleural space. In this case, physical findings are those of either pneumothorax or fluid. 2. Obstructive absorption, collapse. This happens when the quantity of air entering into lung tissue is decreased. Generally it is due to obstruction of bronchi, as in case of foreign bodies, lymph nodes, malignancies, or strictures. In this case, physical findings suggest shrinking of chest wall and lessened air entry in the affected region. 2. Fibrosis. In pulmonary fibrosis, scars are formed in the lung tissues extensively, leading to total shrinking of lung mass, with decreased or no air entry. Normal lung tissue is replaced by fibrous tissue, with thickening of the walls. Clinically, the findings are of shrinking of that side of chest, with decreased or no air entry, and sometimes interspersed with altered breath sounds, with rhonchi and or rales. 3. Consolidation. A pulmonary consolidation is a region of lung tissue that has filled with liquid, a condition marked by induration, swelling or hardening of normally soft tissue of a normally aerated lung. Consolidation occurs by accumulation of inflammatory cellular exudate in the alveoli and adjoining ducts. The liquid can be pulmonary edema, inflammatory exudate, pus, inhaled water, or blood from bronchial tree, or hemorrhage from a pulmonary artery. It is characteristic of lobar pneumonia. Physical signs include: on inspiration, expansion of the thorax is reduced on the affected side. Vocal fremitus is increased on the side with consolidation. Percussion is dull in affected area. Breath sounds are bronchial, maybe there is egophony. Possible medium, late, or pan-inspiratory crackles rales present. Vocal resonance is increased. Here, the patient's voice, or whisper, as in whispered pectoraloquy, can be heard more clearly when there is consolidation, as opposed to in the healthy lung, where speech sounds are muffled. A pleural rub may be present. 4. Effusion, or collection of fluid, in pleural space. A pleural effusion is excess fluid that accumulates in the pleural cavity. Various kinds of pleural effusions exist depending on the nature of the fluid and what caused its entry into the pleural space. They are hydrothorax, serous fluid, hemothorax, blood, or pyothorax, pus, or chylothorax, bile, etc. It may be due to infections like TB, associated pneumonias, malignancies, congestive heart failures, renal diseases. More than 300 ml of fluid in effusion is clinically detectable. Signs include tracheal deviation to the opposite side, decreased movement of the chest on the affected side, dullness to percussion over the fluid, diminished breath sounds, on the affected side, decreased vocal resonance and fremitus, and pleural friction rub, during the onset. A large effusion may cause tracheal deviation, away from the effusion. Five pneumothorax or collection of air in pleural cavity. A pneumothorax is an abnormal collection of air, in the pleural space. Symptoms typically include sudden onset of sharp, one-sided chest pain, and shortness of breath. Presence of air in pleura compresses the lung tissue to collapse. It can be due to chronic obstructive pulmonary disease, such as emphysema, or chronic bronchitis. Acute or chronic infection, such as tuberculosis or pneumonia, or rupture of a bulb in pleura. Lung cancer, or cavities in lung nearer to the surface which may open into the pleura. Injuries to chest wall, especially like a stab wound to the chest, may result into pneumothorax. Physical signs include diminished breath sounds, on the affected side. Percussion of the chest may be perceived as hyperresonant, like a booming drum, and vocal resonance, and tactile fremitus can both be noticeably increased if there is a patent bronchus to the pleura, or decreased if it is closed pneumothorax. Trachea may be shifted to opposite side, and liver dullness obliterated. Sometimes there may be associated fluid collection. It is known as hydropneumothorax. It is detected by a horizontal fluid level below the signs of pneumothorax. Physical examination involves general examination, systemic examination, and examination of other systems. General examinations. With respect to respiratory systems, note both positive and negative points. Note consciousness and orientation time, space, and person. It may be disturbed in hypoxia or hypercapnia. Note type of breathing, especially if it is labored. Examine nose, throat, oral cavity like DNS, infected teeth, tonsils enlarged, etc. There may be bleeding from mouth, pseudohemoptysis. Lymph nodes, cervical, axillary, and inguinal. Cyanosis, presence or absence of cyanosis, helps in treatment. He may exhibit tremors, indicating respiratory failure. Clubbing indicates suppurative lung diseases like lung abscess, bronchiectasis, and empyema. Swelling feet, found in corpulmonal, congestive heart failure, and COPD with or without congestive failure. Systemic examination. Examined under inspection, palpation, percussion, and auscultation. Most important is adequate posture, exposure, and light. Examine the front and back of chest by making patient sit erect and head slightly bent. Examine the sides by asking patient to raise both arms above the head. Inspection. Look for 1. Shape. Normal chest has elliptical shape, in ratio 5:7, breadth to width. Note any bulging, flattening, or retracted areas in chest wall. Normally there are two types of chest. A. Short and stout, namely, thick chest. B. Long and thin, namely thin chest. 2. Note if trachea is shifted, trail sign. 3. Mark apex beat, by noting precordial pulsation. 4. Movement of chest, tells which side is diseased, that side moves less. 5. Examine spine, and note if there are any deformities, like scoliosis, kyphosis, or kyphoscoliosis. Palpation. Confirm inspection findings. Additionally, determine expansion of chest. Chest movements are measured, in males at the level of nipple and in females, below the mammary line. Expansion of chest is normally 5 to 7 centimeters. In COPD, chest is fixed, and the expansion is less than 2 centimeters. It is said to be overinflated chest. Tracheal shift trail sign is confirmed by pushing a finger slowly into the suprasternal notch. Trachea shifted to the side of increased resistance. Apex beat is the precordial pulsation cardiac impulse, lowermost and outermost. It is best felt in lying supine position, felt with palm, and localized with one finger. If not palpable, make him sit, or lie on left side and locate it. Confirm spine deformity, especially for scoliosis, by marking each spinal process. Vocal fremitus. It is same as vocal resonance. Vocal fremitus is the transmitted sound from vocal cords, through bronchial tree and lung tissue, and felt over the chest wall. It is tested with flat or ulnar side of hand. Keep one hand ulnar side, touching the chest wall, and ask patient to say 1, 1, 1, or 99, 99, 99, and assess the conduction of sound to your hand. An increase in tactile fremitus indicates denser lung tissue, as in pneumonia. A decrease suggests air or fluid in the pleural spaces, or a decrease in lung tissue density, as in COPD or asthma. Percussion. Here, changes in density of the lung fields are tested by examining its resonance. Percussion is performed with the middle finger flexor striking the middle phalanx of the other middle finger of the other hand pleximeter, which is kept firmly on the chest wall. Both the sides of the chest are compared. This is performed symmetrically on all lung fields, on the anterior and posterior chest walls, and in infraaxillary areas. Clavicles are percussed directly, and compared with other side. Normal percussion note may vary, from person to person, depending upon type of chest, or area to area in same person, depending upon muscle mass. For example, infraclavicular area has area with less muscle, and suprascapular area has more muscle mass. Normal areas of dullness. Superficial and deep cardiac dullness. The bare area of the heart, that is, left third and fourth intercostal spaces, inside midclavicular line, are dull on superficial, or light percussion, superficial cardiac dullness. It is roughly triangular in shape, and corresponds to the part of the sternocostal surface of the heart, that is both close to the anterior chest wall, and not covered by lung. The rest of the heart is dull on deep percussion only, due to it being covered by lung tissue, deep cardiac dullness. Both dullnesses are masked when lungs are overinflated, as in COPD, and emphysema, because then lungs cover this area. Liver dullness starts in the front of chest, at sixth space, in midclavicular line. Liver dullness replaced by hyperresonance note in left side, because of Traub's space, which is a semilunar hyperresonant space, bounded by left lobe of liver, spleen, subcostal margin, and lower border of lung resonance. That is, as you come down in midclavicular line, on left side of chest, resonant note of normal lung tissue, is followed by hyperresonant note of Traub's space. Traub's space is obliterated in massive pleural effusion, enlarged liver and spleen, pericardial effusions. It is wide in event ration, herniation of lung, paralysis of phrenic nerve, etc. Normal areas of increased resonance. Chronic isthmus, it is a resonant band of 5 to 6 centimeters, connecting anterior to post-chest wall. It may be reduced on one side, indicates disease in the apex. To delineate it, start percussing from shoulder inside first, then from lateral side of neck outwards. Traub's space is a semilunar hyperresonant space, bounded by left lobe of liver, spleen, subcostal margin, and lower border of lung resonance. That is, as you come down in midclavicular line, on left side of chest, resonant note of normal lung tissue, is followed by hyperresonant note of Traub's space. Traub's space is obliterated in massive pleural effusion, enlarged liver and spleen, pericardial effusions. It is wide in event ration, herniation of lung, paralysis of phrenic nerve, etc. One hyperresonant, or tympanic note, suggests more air in alveoli or pleura, COPD, emphysema, or pneumothorax. 2 less than normal or impaired note, suggests early disease, consolidation, early pulmonary edema, or heart failure. 3 dull note, implies consolidation or collapse. 4 stony dullness, is the dullness with an abnormal resistance feeling, during percussion suggests pleural effusion. Pleural effusion may contain fluid in general pleural space, or in C-stead, or with air, known as hydropneumothorax. Percuss in front, side, and back, and mark the upper border of dullness. In fluid-only pleural effusion, the highest point of dullness is in axilla. In hydropneumothorax, upper level of stony dullness is horizontal. In C-stead effusions, the dullness level depends upon position of pockets and is not regular. Shifting dullness occurs in hydropneumothorax. Upper level of dullness changes immediately on changing the posture of patient, especially from sitting to lying posture. Succusion splash. First explain the patient about your action. Then while in sitting position, shake him vigorously, while auscultating. You will hear a splash sound. Another sign is coin percussion. Take 2 coins, keep one firmly on the chest, and tap with another. Then hear from corresponding opposite side. A tympanic note is added to coin sound in positive test. It is indicative of pneumothorax or hydropneumothorax. Shifting dullness can be there in fluid-only pleural effusion also. But it takes 15 to 20 minutes for the upper level to shift, as compared to 1 to 2 minutes in hydropneumothorax. In pleural thickening, there will not be shifting dullness at all. Auscultation. Auscultate the lungs, while the patient breathes normally, with mouth open. Make sure to auscultate the apices, and middle and lower lung fields posteriorly, laterally, and anteriorly. Use the diaphragm of the stethoscope. Listen to at least 1 complete respiratory cycle at each site. Auscultation is to determine 1. Nature of breath sound, 2. Accompaniments, and 3. Vocal resonance. Normal breath sounds. There are 2 types of normal breath sounds: bronchial and vesicular. Bronchial breath sounds are heard over the tracheobronchial tree. Vesicular breath sounds are heard over the normal lung tissue. Bronchial breathing can be normally heard where tracheobronchial trees are close to chest wall. They are trachea, right sternoclavicular joints, and posterior right interscapular space. Differences between vesicular and bronchial breath sounds. 1. Duration of sound. In vesicular breath sounds, inspiration to expiration ratio is 3:1. There is no gap between inspiration and expirations. In bronchial breath sounds, inspiration to expiration ratio is 1:1. There is a gap between inspiration and expiration. 2. Character. Vesicular breath sounds are rustling in character, whereas bronchial breath sounds are hollow or aspirate. 3. Intensity of sound. In vesicular breath sounds, inspiration is 2+ and expiration is 1+. In bronchial breath sounds, inspiration 2+ and expiration 3+. Vesicular breathing will be heard like this. Bronchial breathing will be heard like this. Variations in vesicular breath sounds. Character: vesiculobronchial breath sounds are said to be present if inspiration and expiration are equal. In harsh vesicular breathing, expiration is prolonged. It is generally due to airway obstruction. Intensity: more intense vesicular breathing is known as puerile vesicular breathing. It is heard in children, or in cases where one lung is removed. Decreased or absent vesicular breathing are heard in bronchopneumonia, hydropneumothorax, collapse, fibrosis, etc. Bronchovesicular breathing. Bronchial breathing, with some features of vesicular breathing, is known as bronchovesicular breathing. In these cases, one phase is heard like bronchial, or hollow in character. It is normally heard in superficial bronchus like thin chest, right infraclavicular area where right bronchus is nearer to surface. It is also heard at level of T2 and T3, where trachea and the hyla of lungs are closer to the chest wall. Pathologically, it is heard where superficially bronchus comes in contact with chest wall in emaciation or extreme fibrosis. Bronchovesicular breathing will be heard like this. Bronchial breathing has three types variations. 1. Tubular high-pitched bronchial breathing, heard in consolidation. 2. Cavernous or low-pitched bronchial breathing is heard in cavity communicating with bronchus. 3. Amphoric bronchial breathing is low-pitched and is associated with high-pitched overtones. It is commonly heard in 1. Pneumonia or hydropneumothorax, with bronchopleural fistula, open pneumothorax or hydropneumothorax, and 2. Giant cavity of more than 4 cm in size. Accompaniments of lung sounds. They are rhonchi, crepitations or rales, and pleural rubs. Rhonchi are continuous type of sound, generalized or localized. Generalized rhonchi are common. Rhonchi indicate partial airway obstruction, as in chronic bronchitis, asthma, COPD, etc. Localized rhonchi are more important. However, non-persistent rhonchi like mucoid plugs is not important, and they usually disappear on coughing. Persistent localized rhonchi means partial obstructions with causes like outside endobronchial tree like lymph nodes, tumors pressing over bronchi, etc. The cause of obstruction may be in the wall of bronchus like endobronchial TB, malignancy, or it may be within the lumen like FB aspiration. Wheeze will be usually heard like this. Crepitations or rales. They are intermittent sounds, and they are fine or coarse or heard phase-wise. Fine crepitations are present in late inspiration. They indicates early pneumonia, etc. or interstitial lung disease. Coarse crepitations are present in both phases. They originate in major bronchus like COPD, bronchitis, bronchiectasis. They are persistent and localized in bronchiectasis or cavity. Rales or crepitations will be heard like this. Pleural rub. It is an almost continuous sound, heard both in inspiration and expiration. It is caused by pleural diseases, like inflammation, malignancy, pyogenic pleuritic, TB, etc. It is rubbing sound, and not changed on coughing, typically heard by scratching stethoscope diaphragm with edge of a paper. It increases in intensity on pressing chest wall by stethoscope. Whereas crepitations are intermittent and change with cough. Pleural rub disappears with pleural effusion and may reappear on treatment, when fluid is decreased. Pleural rub will be heard like this. Vocal resonance. It is same as vocal fremitus. It may be increased or decreased or absent. Normally it appear to originate at chest wall. In consolidations it is increased and heard nearer to the ear. When increased, whispering is also clearly audible as if whispered in ears, and is known as whispering pectoraloquy. Egophony is increased vocal resonance, when nasal twang is added to the conduction. It is usually present in consolidation, and at the top level of pleural effusion. Vocal resonance may be decreased or absent in the presence of effusion or collapse. After the respiratory system, other systems should be examined. Like abdomen, especially in right-sided pleural effusion or pneumonia, etc., or CVS in hemoptysis, or suspected right heart failure.